Hello and welcome to this VJHemOnc podcast, where we'll be exploring how precision medicine is reshaping the management of myelodysplastic syndromes, or MDS. This podcast is part of the Myelodysplastic Syndromes channel, which is supported with funding from VERONA. The supporter has no influence over the production of the content. Advances in genomic profiling and targeted therapies are reshaping the diagnosis, risk stratification, and treatment of MDS. In this episode, we'll explore how precision medicine is helping refine disease classification, inform therapeutic decision-making, and guide the development of novel treatment strategies. This podcast is intended for healthcare professionals only. Let's begin. Precision medicine relies on accurate molecular characterization to define disease biology and inform clinical decision-making. Alex Bataller discusses how whole genome sequencing is expanding our understanding of the genomic landscape of MDS and its potential clinical implications.
So in this study, basically what we did was to test some samples that we already tested with our standard of care procedures that include cytogenetics, sometimes OGM, and also NGS. We compared that to a more wide approach that is the whole genome sequencing, to see if the results were comparable or if that there were some things that were missing. And actually, we found some very interesting results, for example, in some of these patients in which the NGS and OGM and cytogenetics were showing not that many important findings. With the whole genome sequence, for example, we found cryptic MECOM rearrangements, also some other abnormalities, and these actually impacting the survival, basically in the prognostication and survival of patients. So I think that with better tools to diagnose patients that include, for example, whole genome, first we can detect cryptic abnormalities that we will not detect with the current standard of care, but also we may also identify novel genes, novel alterations that for now we're missing, and that they could have a potential prognostic and survival impact.
As genomic technologies continue to evolve, more comprehensive molecular profiling may improve risk stratification and provide a stronger foundation for personalized treatment decisions throughout the MDS disease course. In lower-risk MDS, treatment strategies are evolving beyond supportive care towards more individualized therapeutic approaches. Pinkal Desai discusses the evolving role of luspatercept and the emerging evidence that its benefits may extend beyond erythroid response.
We are certainly talking more than anemia response and symptomatic control with the data that are currently being read out with the frontline setting with the COMMANDS trial. There is a trend towards survival benefit, and that's a trend only because the trial was not designed or large enough to show a survival benefit. That was not the primary endpoint, and yet there was a trend towards survival benefit. I'm sure that if the trial was bigger, you would actually see that p-value also move in the direction of actual statistically significant benefit. The lower risk MDS, we didn't have agents like this before, so we've always been talking about anemia improvement. But as we are seeing these data, low-risk MDS has, these questions are now being raised that can be modified the disease. There's lots of data with luspatercept that support that mechanism, right? The erythrocyte stimulation is just part of it, but it also has anti-inflammatory effects. It has trilineage effect where you can have a platelet and neutrophil response as well, which is important in terms of infection and bleeding. And the cardiovascular modification, patients who are on the COMMANDS study, when they were responding to luspatercept, there was a reduction in NT-proBNP, which is a predictive marker for future cardiovascular risk and mortality. So patients are having better cardiovascular biomarkers on luspatercept. There was a reduction in hepcidin. Again, it's an inflammatory it's a marker of higher inflammation in the body. So as we modify these predictive biomarkers that tell us about the future risk of mortality, we are doing two different things, right? We're not only trying to improve survival by modifying their other comorbidities like cardiovascular disease, But at the same time, also, as luspatercept moves more and more in the frontline setting, and the potential, and even at the point where they're NTD or non-transfusion dependent, that we have the ELEMENT study, which is ongoing in that as well. We're using luspatercept earlier in stages where the anti-inflammatory effect might actually be important in dose modification. So we certainly are moving in a direction of, can we actually modify the disease and make our patients live longer rather than, we're just doing it for the anemia.
These data raise important questions about whether earlier intervention could modify disease biology, as well as improve hematologic outcomes. Optimizing treatment timing represents another important aspect of personalized care. Sophie Park presents results from the Phase III EPO-PRETAR trial, which investigated early versus delayed initiation of erythropoiesis-stimulating agents, and explains how the ESA IPSS-M score may help identify patients most likely to benefit.
So this was a Phase III GFM trial aiming at answering the question, do we have to initiate ESA early in lower-risk MDS patients with anemia, or after waiting the transfusion threshold? So we designed a prospective trial to answer this question, and there were two arms. In the early arm, the ESA was introduced when the hemoglobin was between 9 and 10.5 grams per deciliter. And in the late arm, ESA was introduced when the hemoglobin dropped below 9 grams per deciliter, near the transfusion threshold. So therefore, we enrolled 84 patients, 43 in the arm A and 41 in the arm B. And the median delay of initiation of EPO was 0.2 months in the early arm and 16 months in the delayed arm. Both groups were well balanced in terms of age, gender, IPSSR, IPSS-M. And the primary endpoint was transfusion dependence, the delay of transfusion dependence. And finally, there were no difference in the early arm versus the delayed arm for transfusion dependence. Nevertheless, the response rate was higher in the early arm, 85% versus 55%. This was clearly significant. And the duration of response was numerically longer in the longer arm, 32 months versus 20 months. So then after we evaluated the molecular IPSS-M to see whether it could predict a response rate, and both groups were well balanced in terms of IPSS-M and gene mutations. But when we evaluated the ESA PSS-M score, which was published last year by Marco Radi and Valeria Santini, so this score integrates endogenous erythropoietin level and IPSS-M. And there is quite a complex formula to calculate that. But to be simple, when the score is high, the better the response and the longer is the delay of transfusion dependence. So in the early arm, it was striking to see that this score could predict the patients with a higher response rate and with a longer delay of transfusion dependence. So to summarize, early initiation of ESA did not delay transfusion dependence, but it leads to a higher response rate to ESA. And simple molecular and score, which integrates endogenous erythropoietin level, can predict a subset of patients who will benefit from this early initiation of ESA. So these are the results of our poster today. And we analyzed the transcriptomic, cytokine profile, and the site of analysis of these patients included in the EPO-PRETAR trial. And the take-home message are that transcriptomic signatures showed that the responders, the early arm responders, have an increase of gene expression in the interferon gamma signature. And in the late arm, there are some signature correlated with inflammation. And These results were confirmed by cytokine profile, where early arm responders secrete interferon gamma with T cells and NK cells. And whereas in late arm non-responders, you have an inflammatory milieu with IL-6 and IL-10. So therefore, it seems that the early responders have an adaptive, favorable immune microenvironment, whereas the non-responders have inflammatory milieu which impedes ESA to lead to response.
Together, these findings demonstrate how clinical and molecular parameters may help identify patients most likely to benefit from specific treatment strategies. Patient selection is also emerging as a key consideration in higher-risk MDS. Alex Bataller discusses a retrospective analysis of hypomethylating agents with or without venetoclax in patients with MDS and excess blasts, highlighting patient subgroups that appear to derive greater benefit from combination therapy.
So in our analysis, what we did basically was to analyze a retrospective cohort of patients treated with either HMA or HMA and venetoclax. All of them were patients with MDS and excess blasts. Now, what we found is that patients with HMA-Ven had a superior overall response rate compared to HMA, although if we compare head-to-head, both the survival was kind of like similar, around like 19 months of median overall survival. Now, when we looked specifically at some subgroups, we could see that there are some subgroups, like for example, patients with ASXL mutation or patients with a blast percentage more than 10%. Those patients seems to benefit most of the addition of venetoclax compared to HMA single agent. So this is what the key findings, also that transplant really impacts in survival in both in patients either treated with HMA and HMA-Ven. So basically we need to find out which are these subgroups of patients that may benefit from Ven, and also what is the role of transplant in combination with HMA-Ven in these patients.
These findings support ongoing efforts to identify biologically defined patient subgroups most likely to benefit from venetoclax-based therapy. Novel immunotherapeutic approaches are also expanding the treatment landscape for higher-risk disease. Mika Kontro discusses the macrophage-targeting antibody bexmarilimab and updated findings from the BEXMAB trial evaluating its combination with azacitidine.
First, starting, what is bexmarilimab? So CLEVER-1 is actually immune suppressive molecule that is expressed on the macrophages and monocytes. With bexmarilimab, we can actually target CLEVER-1, and basically that leads to enhanced antigen presentation, enhanced HLA-DR expression, and also T-cell activation and cytokine production. And in the BEXMAB trial that we conducted, which was Phase 1/2 trial, we actually included 20 patients with previously untreated high-risk MDS and 32 patients with HMA-failed MDS. We have some updates on the results regarding the frontline patient population. 45% of the patients achieved CR responses, and we have now updated the duration of CR. The median duration is 16 months. When looking at HMA-failed patient population, the overall survival median is 14.5 months, so it continues to hold strong. And then for a patient population, the overall response rate is 64%. So basically what we actually presented at this meeting, we wanted to evaluate that what's happening in the patients when we are treating them with azacitidine and bexmarilimab. First of all, based on the single-cell RNA sequencing data and spectral flow, we were capable of showing that, first of all, quite interestingly, we see elevation of erythroid progenitor cells, and perhaps that might also translate to hematologic improvements. In addition to that, we actually also saw quite interesting differences in T-cell populations, comparing the responders and non-responders. So for responders, we observed that these patients actually had more central memory T cells, whereas non-responders had increased amounts of T cells that were kind of exhausted, and that perhaps these actually can be then validated later on in the upcoming Phase IIb trial, which will be a global trial recruiting patients for frontline population across the globe.
Despite these advances, significant unmet needs remain for patients with adverse molecular features. Thomas Cluzeau discusses the current management of TP53-mutated MDS and the need for more effective treatment strategies.
Today, as you know, where the TP53-mutated MDS are very poor outcome. So today we continue to treat this patient with azacitidine, and if by chance, if we obtain a response and if the patient is eligible to allo stem cell transplantation, we try to transplant this patient. We discuss also to use after transplant a maintenance treatment using azacitidine or azacitidine plus DLI in prophylactics, because as prophylactic treatment, because we know this patient relapse. So this is the standard of care for today for this patient. But unfortunately, if there is no transplant, the median overall survival of the patient stay around 6 to 9 months. So we try to design some clinical trial to improve the outcome of this patient. And with the French group of myelodysplasia, we designed some clinical trial, and we hope to open some clinical trial very soon in first line, but also in second line in a relapsed refractory setting. And we hope maybe to improve the outcome of these patients.
Several early phase targeted therapies are also being evaluated in molecularly defined patient populations. Eytan Stein discusses the first-in-human evaluation of the CLK inhibitor BH30236 in relapsed or refractory AML and higher-risk MDS, including its potential activity in splicing factor-mutated disease.
So this is a really exciting trial. It's with a CLK inhibitor, which are a class of compounds that may have preferential activity, although we don't know yet, in patients with splicing factor mutant acute myeloid leukemia and high-risk myelodysplastic syndromes. What we've seen in the trial to date and what we're presenting in a poster is that monotherapy with this agent is well tolerated. We've seen some diarrhea, but it's been manageable. We have seen some blast reductions with monotherapy. But then when you give the drug in combination with venetoclax, even in patients who've previously been exposed to venetoclax, we're seeing some real responses and some real complete remission. So we're very excited about this data, excited to expand out the trial and treat more patients, see how many more responses we can get.
Looking ahead, precision medicine is expected to play an increasingly important role across the MDS treatment pathway. Alex Bataller discusses why future MDS management will depend on integrating genomic and clinical characteristics to identify the patients most likely to benefit from individual therapies. He also reflects on the lessons learned from the VERONA trial and why understanding biologically defined patient subgroups will be key to future progress.
Yes, so I do believe that we are going towards an era in which we are not going to treat all MDS the same. We know that every MDS is very heterogeneous, so there are patients with like different mutations. Also, epigenetically, it's a very complex disease. So we are treating all these patients the same, and this in this era makes like no sense. So I believe that we are going into an era in which like treatments, also prognostication is going to be patient. We're going to be centered into the patient. So we're going to decide which clinical trial, what is the prognosis, etc., based on the biological characteristics of that disease. In AML, HMA-VEN is a standard of care combination after demonstrating that it's better than HMA alone. But in MDS, although early clinical trials were showing promising results, the VERONA clinical trial really didn't met its primary outcome, which was like overall survival. So the main question now is like to understand why VERONA failed and likely identify which subgroups of patients, maybe genomically defined, maybe because of like clinical characteristics. There should be some patients that may benefit from the addition of VEN. Maybe not all patients with myelodysplastic syndrome, but some of them may benefit. So we need to identify, understand who these patients are to treat them appropriately. Likely, I think that novel treatment combinations are going to come into the MDS field that actually will provide some insight in terms of like which treatment may be added to HMA, maybe not added to HMA, could impact in the response rate and also survival in MDS patients. So likely novel treatments will need to be explored to see if they are like useful in the field of MDS.
Precision medicine is reshaping the management of MDS, with advances in molecular profiling helping to refine disease classification, guide treatment selection, and support the development of novel therapeutic strategies. Thank you for listening to this VJHemOnc podcast. For more expert interviews and updates in myelodysplastic syndromes, head over to VJHemOnc.com. Be sure to follow us on X at VJHemOnc and subscribe to our podcast on Spotify, Apple Podcasts, or Podbean.